about designing the PICU with Dr. Abdullah Al-Wad'i. Dr. Abdullah Al-Wad'i, he's a senior pediatric cardiac intensivist on the region. He probably establishing many ICU before, and he started the process of the steps from before. So this talk is very important in terms of safety as well as quality and future thinking about starting ICU work. Dr. Abdullah, if you don't mind, could you share your slide if you don't mind?
Is it clear? Bismillah, assalamu alaikum.
Very clear, and the voice is clear. Guys, we have around 117 participants, and we have a few questions for the participants in order to know some of the information about design and operating the ICU. I will start with the first question. You can launch it in your Zoom and you can answer that. We're going to go for that within 45 seconds. So the first question is, the good PICU bed capacity is 4 to 10, 6 to 16, 10 to 20, or 15 to 25. Abdullah, most of the answer going toward like 40% of the people from 4 to 10, and 35% of the people think it is 10 to 20. And this is the most answers we got. So the second question is for PCICU, pediatric cardiac intensive care. So the number of the surgery per years that require to decrease the mortality rate. More than 150, more than 200 surgery, more than 250 surgery, and more than 300. Okay, for Abdullah, I guess people think more than 150 probably will be, that's the number needed to decrease the mortality rate. And this is most of the, like, people choose this this choice. So we're going to go for the next question, which is what is the recommended space for patient on single room on pediatric cardiac intensive care units? It will be a 10 meter square, 12 meter square, 18 meter square, or 23 meter square. This Dr. Abdullah, most of the people is ranging from 12 to 18 meters square. And this is I think the capacity probably needed for a patient of the pediatric cardiac ICU. So the last question is what the recommended electrical outlets for a patient on pediatric cardiac ICU units. 8 or 10, 12 or 15. As you see, Dr. Abdullah, probably most of the people going with 10, with choosing how many outlets needed on pediatric critical care, pediatric cardiac ICU units. So, Dr. Abdullah, you have the floor for you, and you can start.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Ali, for the introduction and the questions. And كل عام وأنتم بخير ورمضان مبارك إن شاء الله. I would like to thank you all for staying late. I hope you will have something out at the end of this lecture. I prepared for you a few slides. In fact, I love to talk about this topic for a long time, because when I came back from my training, the first thing I was faced in my previous hospital was a new renovation for the unit, and I was asked these questions: how many outlets? What is the size of the patient space? So it was difficult for me to answer this question. Then again, when I joined the BSCC 4 years ago, I went through the same experience. I was asked these difficult questions from clinical point of view. So I wanted to share with you a few ideas. After reading about this topic, I had a discussion with my friend Dr. Yasser Gazzaz, about this topic, and I thought maybe if we discuss this in our chapter, we'll have an idea about it. Initially, I chose the title to be the virtuous PICU, or the utopianism of the medical care. As you know, the great philosopher Plato, who wrote the book The Virtuous City, then the Sir William Moore, he wrote another book called Utopia, which is mean nowhere, or no place, or a good place, where you imagine a perfect place to live in, but actually it's not there. So do we have this in medicine, especially in PICU, more specifically in pediatric cardiac ICU? Do we dream of a unit that's really virtuous and it's not existing, or we can make this happen in reality? So I have nothing to disclose for this talk. I will share with you a few ideas about the history initially, then design and operation of the ICU. I wanted to start with this article that was published by the World Society of Pediatric Congenital Heart Surgery group. Before they have their own journals, they published this article in Cardiology in the Young in 2008 about their vision for the pediatric cardiac care in the world, actually. So according to this article, this is what they wrote in the abstract, actually. Every year, approximately 90% of the more than 1 million children who was born with congenital heart disease across the world receive either suboptimal or are totally denied of the care of the cardiac surgery. Although the developed world now focus has changed from the effort to decrease the postoperative mortality, because they achieve or almost achieve the target, and now they change the target to improve the quality of life and decreasing the morbidity. Yet the rest of the world still need to develop basic access to congenital cardiac care. So between these two images, the virtuous one and the reality one, where do we stand? Imagine yourself sitting in an office and have these screens in front of you. You can look into the ICU patients from your office. You can zoom and examine the patient. You can check the labs and you can check the x-rays. At the same time, you have patient in the OR. You can zoom to the patient. You can talk to the surgeon. You can see the operation live. You can have the instantaneous live report from the anesthesia and the surgeon. So you know the patient exactly before he comes to the ICU. The patient comes to the ICU, again, you can see him from your office. You can zoom, you can ask the nurse to show you a part of the body so you can actually virtually examine the patient. You can look into the data, to the monitor. You can know exactly what's going on. Then you found that the patient in need for some medication like epinephrine, for example, you want to order epinephrine. You can do this in your tablet or your cell phone by the application. Immediately you order the medication on the application. The nurse on the bedside will have notification that you order something. Then she will just know that because your medication that you order will go directly to the infusion pump, because this is our smart pump connected to the cerner. So the nurse even does not need to change the rate, because it's going to be changed automatically. So this is the unit that we dream of, that has all these facilities, the view, the space, the layout, and the equipment. However, not everywhere we have this luxury. Some hospitals still care for ICU patients in such facilities, and some even worse case like this one. And I'm sure few of you who had been in charity trip have cared for a patient post-cardiac surgery in similar situation. So between these two extremes, where do we stand? Let's talk about the history of PICU for a little bit. This article was published in 2014, talking about 60 years. So it's now 70 years of the history of the ICU. And we all know that the real ICU was started in 1930 with the polio endemic, with the use of the iron lung for patients who had respiratory failure secondary to the polio infection. However, we in pediatric, those patients with polio, some of them were pediatric, so they were cared by those machines in those setting. But actually, it's our friend in neonatology and the NICU who started the intensive care unit for neonate. Then they were able to make them survive after they got sick in the first few days of life. And that was in 1950s. In 1960, we as a pediatric doctors inherited those neonates, and we have to continue taking care of them when they survive the neonatal period. So the first pediatric ICU was actually established in Sweden in 1955. 10 years after that, the first one in North America was in Colombia, then 1967 in Philadelphia. So these are the first three pediatric ICU was established as a distinct unit. The Society of Critical Care Medicine started as an adult, but recognized the pediatric chapter in 81. Then the American Academy of Pediatrics created the section of critical care medicine in 84. So we are actually fairly young subspecialty. And this subspecialty has grown very fast. For example, in 1995, only 25% of pediatric graduates applied for pediatric intensive care as the subspecialty. In less than 10 years, in 2004, 7.5% applied to be a pediatric intensivist. And this is because in the past, the ICU bed was composing only 3 to 5% of the hospitals. Nowadays, it's around 20%, and it's expected in the future that each hospital will have up to 30% of the bed as ICU. For example, especially in those in the subspecialized hospital. For example, our hospital, the ICU bed is around 35% of the beds are intensive care or high dependency unit. So the subspecialty is growing. The need for more intensive care doctor is growing. Particularly about cardiac, because we are in the cardiac chapter, the need for a post-operative care for congenital heart disease started from the first time that the cardiac surgery was done in 1953 using cardiopulmonary bypass. Although before that, in 1938, a BDA was ligated and arch was repaired, but the first real cardiac surgery was 1945 with BT shunt. Then after that, the cardiopulmonary bypass surgery was started, and the need for specific cardiac ICU was established at that time. And because of the recognition of the complexity of cardiac intensive care, some intensivists choose to receive more training in the cardiac side, so they become pure cardiac intensivist rather than general pediatric intensivist. If we talk about the design of the ICU, I will start with this article that was published almost 30 years ago, talking about the same. This is at the beginning of the ICU as a design and a specific unit. This published in 1993, and just mind the name, this Dr. Klinani, because he published another paper 30 years after that. This is actually a very good, although it's an old one, but he talked about every single thing in the unit. That talked about storage room, dirty utility, clean utility, linen, physician and call room, family waiting area. So it was an excellent start of a paper in that field. He talked about the ideal size of the ICU, and he said it's not known, but usually between 6 and 16 bed is the best, because of less than 6 bed, it become risky for insufficiency, and unit larger than 16 beds may be difficult to manage unless appropriately divided. And we know that in practice, small unit is usually insufficient, big unit is difficult to control, especially during the night shift. He also recommended that 50% of the patient room has to be isolation. I know some of the units nowadays is all isolated room, but it's not practical in some cultures and some low resources area. The critical care group actually published this excellent guidelines in 2004. They set the ground for those who wanted to establish a pediatric ICU. At that time, they divided the ICU to 2 levels. Level 1, which is the high acuity ICUs. Level 2 is the community pediatric ICUs. That was also used in 1993, but continued to be used in 2004. I'm not going to read all of these, but in this particular paper, they have tables for every single thing that you might think of in the ICU. The 2 level, level 1 and level 2, they divided it to essential, desirable, and optional. And they talked about anything from organization, staffing, nursing, even the other subspecialty, the pharmacy. So it's all in there. How do you monitor the patient? So if you are going to build an ICU, I recommend you to read this paper because it's going to help you a lot. They recommended to have a PICU committee that should be established and stand alone. And it should be having a member of intensive care doctors, nurses, respiratory therapists, clinical pharmacists, social worker. This group has to establish the guidelines, the policy and procedure, and even to give the privilege to the all members who work in the ICU. And the location of the ICU should be studied, because it has to be located close to elevators, to the ICU, as to the emergency room, and to the OR and CAT in case if there is a cardiac surgeries. The facilities, we talked about this a little bit. So one of the question was the size of the bed. So this is the optimal, this is the dream ICU bed. So they recommended that the PICU individual patient room should be allowed at least 250 feet square, which is around 23 meters square. Assuming 1 patient per room. So I think this is a luxury, because if you think about the unit that you are working in, rarely you will have a room that's this big. That's meaning you should have a room that is at least 4 by 5 meter to achieve this space. If the patient is going to be cared in a ward type PICU, they allow at least 225 feet square, which is around 20 meters square or 21 meters square, which is still a lot. For example, the unit I'm working in is barely having this meter square in the patient area. In most of the cases, 12 or more electrical outlets, minimum 2 compressor air outlet, 2 oxygen outlet. This is just one of the recommendation, and you can imagine. For example, when I was asked this question, in my mind was 8 is enough, but apparently the new recommendation actually 15 outlets should be for each patient, because the ICUs that have procedure, especially chest closure or opening ECMO, they will need a lot of outlet. They will need a lot of compressed air. They will need a lot of vacuum outlets. So the more you have, the better, actually. The same group from the Critical Care Society and the Pediatric Critical Care Medicine Journal published in 2019 an update for the criteria of imminent children, PICU admission, discharge, and triage. They changed the level of care. Now, the one I told you was 2004. They were having only 2 levels of ICU, 1 and 2. But now they changed because a new big facilities have appeared in the field itself, and they created something called quaternary PICU, which is a facility that care for a patient in University Hospital in North America, because the University Hospital usually the largest. They can provide the whole spectrum of care, from simple respiratory distress to the maximum, which is transplant, bone marrow transplant, organ transplant, and all included. These are the quaternary PICU. Another type, they call it specialized PICU, which is like the unit we have, the cardiac ICU, the burn ICU, the neuro ICU, a unit that's specified to care about a single organ problem, like the cardiac ICU. Then the other ICUs, the tertiary, which used to be called level 1, which is the ICUs that do everything except transplant or specific care like cardiac or trauma or burn. And the last one is the community PICU level, which is the ICUs that can intubate patient, ventilate, but cannot do more than this. They can care about simple to modest type of diseases. In the same article, this one in 2019, they also updated the recommendation. I'm not going to read it all, but I wanted to read the last paragraph. Congenital heart surgery should only be performed in a hospital that has PICU with dedicated pediatric cardiac intensive care team, including but not restricted to pediatric intensivist, nurse expertise in cardiac intensive care, cardiovascular surgeon with pediatric expertise, pediatric perfusionist, pediatric cardiologist, and pediatric cardiac anesthesiologist. The recommendation is long and it talks about everything, and it's also a good reference for those who are going to be a director or involved in designing a new ICU. The only thing I want to stop is the staffing. So you can see that they recommended to have 24-hour staff coverage, doctors at a level of R2 or above, but the consultant has to be available within 30 minutes from the hospital. Not only that, but look at the recommended to have, I'm going to discuss this later at this talk, they are also promoting an advanced practice provider, or to what we call nurse practitioners, and it's desirable in all level of the ICUs. So maybe that's the way we should go in the future, because of shortage of physicians who worked in the ICU. SIPAHI is a good step to maintain the quality of care that we provide in the hospital in the kingdom, and there is a chapter specific for pediatric intensive care unit, and it's a very good one, though it's not very detailed, but it's cover most of the important area and to make sure that the design, the functionality of the ICU is optimal. This is the article I told you in the beginning. In 2020, Dr. Praveen Kilnani also published the guidelines. At that time, the first one, he was in the state in Georgia. This time he was back to India. So it can show you the two extremities. Somebody who worked in the state, then he went back to India, and he published the guidelines at the 2 times. So look at the size of the PICU, because it's not always easy to have a big ICUs. So 6 to 12 beds is desirable, because less than 4 is insufficiency, more than 16 is difficult to control. And he recommended that for each 4 bed in the ward, you have 1 bed in the ICU. So 25% of the hospital bed should be intensive care. This is the size they recommend in India. The patient area that's open has to have, for each one, 9 to 14 meters square. And if the patient is cubicle, which means that the patient is in his own room, it should be around 11 to 18 meters square. However, if there is an isolation room with anteroom and negative pressure, the room has to be big, 250 square feet, which is around 23 meter square. The efficiency, so we have, these are like guidelines, but the efficiency of the unit is that it is small enough for the care provider to be fully aware of all activities on the unit, yet large enough to permit sufficient staffing. So the huge unit are not good. The small unit also is not good. So you have to tailor your unit size based on your population. I asked our engineering department I gave them an idea, and I asked them to draw it for me. So in my mind, this would be a perfect design for ICU, especially ICU that care for a patient after cardiac surgery. So this door comes from the OR and cath lab. The patient will come to the ICU. This is the central station. As you can see, the nurse or doctors will sit here, and they can see all the rooms on both sides. In the back of the unit, there will be the doctor on call room, the lounge for the nurses, the store, the RT rooms, some facilities for the staff. In here, it will be the store for clean and devices as well, the office for the head nurse and charge nurse, and this will be the entrance for the visiting families in here. This will be the elevator. So in my mind, I think this is, it's not a design, one design fit all, but I think this is a good background for a good design for a cardiac surgical ICU that make sure that you can control the patient's area. You have enough space to store. You have enough space for staff to be around, and you don't need to go out the unit. The European group or the European Association for Cardiothoracic Surgery, they published this article in 2003 about the optimal structure of the whole congenital heart surgery department, because the European people are very careful about spending money, so they want to make sure that each dollar is counted for. So they recommended that the average number of beds required depend on the complexity. However, 6 to 8 bed is good ICU to be able to perform 250 cardiac surgery per year. And they recommend 1-to-1 nurses for difficult cases and 0.5-to-1 for simple cases. They also recommend that the optimal activity for neonatal surgery, they wanted to do 250 per year. 100 of them is a neonate or infant to be able to maintain the skills of the surgeon. They recommend to have 2 surgeons, at least each one of them will do 125 because they are going to work for 42 weeks per year. So they can manage to do 250 operations per year. And if they are 3 surgeons, they should be able to do 375 surgery per year. This unit of 8 beds that can operate for 250 patients should be able to serve a population of 4 to 6 millions in the European countries. I'm not sure this is applied in our area because I think the congenital heart disease is more in number and more complexity in our population. This is about the design of the ICU, but how do we operate the ICU? we used to be very aggressive in the ICU management, but with time we learned that actually less is more. And we now use this concept in all the medicine, especially the ICU. So we are using lower tidal volume, lower peak and plateau airway pressure. We're accepting lower mean arterial pressure, lower cardiac output than 10 years ago. We're keeping the patient comfortable in a state of comatose, so we are using less sedation. We are transfusing less blood. We are very conservative nowadays in blood transfusion. And there are now suggestions even to use less nutrition. So the ICU care tend to be less intense than before, because we know that in the future the ICU will become more and more part of the so more of the hospital bed will be ICU. So we have to take this in consideration when we design this one. Also, to make sure that we operate the ICU very well, we make sure that we send the patient to the right place. This is a study in Sweden in 2000. They looked at their patients who were operated in 4 cardiac centers in 93. They between 88 and 91, they make those 4 centers to 2 centers, and they looked into the data. They were able to reduce mortality from 9.5% to 1.9% by just centralization of pediatric heart surgery in Sweden. That's applicable. In the state, they did this California state between 95 and 97. By statistical calculation, not real study, but theoretical analysis, if they regionalize the pediatric cardiac surgery, they should be able to reduce the surgical mortality from 5.3 to 4.08 in California. However, when they looked deep into that, they found that the risk of operative death decreased with increased volume load, and they found the cutoff limit for this cohort was the mean annual volume of 60 neonatal operation, which means that if the center is doing 60 neonatal surgery, that's mean they are big enough to be able to maintain a reasonable mortality in comparison to those centers who are doing less neonatal surgeries. Although the higher risk cases is clear that the mortality is lower in high volume centers, the available evidence failed to show significant difference in mortality based on the number of cases done per cardiac center per year for the low risk category, like 3 or below. So category 4, 5, and 6 has to be done in high volume because the mortality is better when it's done in high volume. But the low risk category, like 1 and 2 and 3, actually the mortality is not different. If you do them in, for example, an ASD in a small volume center is not actually different from an ASD done in a high volume center, at least by the evidence that we have for now. And to define what's a big center and what's a small center, it's acceptable that in pediatric field that we call small center that's do less than 150, medium 150 to 249, 250 to 349 is a large center. But if the center is doing more than 350 cases per year, this is a very large by all means of cardiac surface. And to have a good outcome in the PICU, the deflection point was 250 cases. So if the center is doing 250 cases, their improvement is dramatic. This is the deflection point where the mortality decrease, the complication decrease, because this become a high volume center. Some people say 300, but at least 250 is the number that you are looking for. The optimal cardiac center also should have an ICU with 6 to 8 beds and high dependency unit of 2 to 4 beds to be able to ventilate. So sorry, to vent to patient to those area before they go to the ward. After reading a few articles, I came up with this calculation. So each 2.5 ICU bed need 1 full consultant intensivist with a minimum of 3. So it's unfair to an open ICU, even if it's less than 7 beds with less than 3 consultants. So because they will burn out if they are doing 1 and 2 on calls. 1 junior doctor for each bed, minimum of 4 doctors to be able to cover the surface for 24/7 in the ICU. having a good design of the ICU, having the best layout, the best space, the best available technology is not enough, because without utilizing them by the staff in the ICU, nurses and doctors and RT, that will not make a good care. So this is a nice article that was published in 2018 about making care better in the pediatric intensive care. I just want to see this table from that article. It's about the cost of healthcare acquired condition. Look at, for example, simple thing, catheter-associated urinary tract infection. It cost 1,000 to 7,000. But look at the sepsis, 65,000. Look at this is very was shocking to me that unplanned extubation cause actually unplanned extubation $100,000 extra cost for this simple acquired condition if we don't care about it. So the conclusion of this article was very nice actually. It says the complication and adverse event from procedures and treatment in the PICU are no longer acceptable as the price for admission for critical care. The development and maintenance of robust culture of safety is vital first step in ensuring that these complications are eradicated. So we all have to work to eradicate those complications. We have to train more people, because today we had the visit from Saudi Council for our program, and they were like questioning why we did not have a candidate yet. But look at this, in the state itself, 50% of the seats were empty for a cardiac intensive care training, because this is not only subspecialty, it is a sub-subspecialty training. So people finish their training when they are really old. They don't want to do more training to be a cardiac intensivist. So we will have deficiency in this field for many years. And the program that they are proposing actually is taken from the state. In the state, the program is, if you do cardiology training for 3 years, you can go for 1 year and become cardiac intensivist. I was against this when I was in the committee, so I left it, because I don't believe that you can be a good cardiac intensivist with only 1 year of ICU training. And I found this very nice commentary on that program proposal by, look at these names, Big Shot, Jerry Zimmerman, Randall Wetzel, all big names in the pediatric ICU field. Their commentary about pediatric cardiac critical care patients should be cared for by intensivists. And they stated very nicely, although it's very true actually. They said, we acknowledge that cardiologists who completed abbreviated critical care rotation outlined in the American College of Cardiology Foundation, American Heart Association, American Academy of Pediatric document will have added the critical care skills, but this additional clinical experience does not transform cardiologists into any more. New of cardiology training could convert an intensivist into cardiologist. It's clear that you cannot be a good cardiac intensivist if you have less than 2 years of ICU training, even if you are a cardiologist. Quality control is very important in operating a cardiac ICU, pediatric cardiac ICU, and the best variables for measuring quality are still unclear. But people agree on readmission rate within 24 hours, reintubation rate, duration of blood, and morbidity and mortality meeting. These are important quality indicators for any ICU, especially the cardiac one. How do we balance between just and cost-effective ICU care? We should do what is needed only. You remember that the ICU care costs around up to 20% of the congenital heart disease surgery. So we should work to reduce this by early extubation, reduction of lab tests that are unnecessary. I hate to hear that this is a routine lab. There is nothing called routine lab. The lab that you do should have a reason. Otherwise, there is nothing called routine lab. Medication has to be refused, and you can use alternative. There are good alternative that's less costly. Reduce unnecessary blood product usage. If your patient doesn't need blood, don't transfuse him. If he doesn't need platelet, don't transfuse him, because it's costly and it's risky for the patient. Aim for the early de-intensification. So if the patient is stable, less than 12 hours from extubation, he doesn't need to be in inotrobes, he doesn't need an arterial line. You have to do these things: remove lines, stop medication, discharge the patient, use clinical pathways, because it's proven that the more you have clinical pathway, the less time the patient will stay and the less cost he will cost. I would go through this article, which is done by an Indian team as well, because they established an excellent cardiac ICU in Kerala, and they published something about it. So why do we need a dedicated pediatric cardiac intensive care? Because published data showed that the patient after cardiac surgery do much better when they are cared in a dedicated cardiac intensive care. In that area, you can accept between 14 and 18 meters square for patients. Also, you can manage an 8-bed ICU, but you have to have a scope of the future expansion for that unit. The cardiac patient can be cared in a general ICU, pediatric general ICU, or can be in a dedicated specialized cardiac intensive care, which is the best. And sometimes they can be shared, they can share this. For example, when I was at King Faisal, we used to share the space and staff actually of adult ICU. We separated after like 20 years of this practice. So it's practical if you have just started the program to be an umbrella of general ICU or cardiac surgical ICU, but at the end, you have to have your own dedicated unit. ECMO is an important part of it, but remember, there are several programs that achieve an excellent outcome without having an ECMO. Yes, ECMO is good, it might save lives, but in outcome can be good without even an ECMO, because you will be able to choose your patients. Frontline, most important part of the ICU care are nurses, but they have to be very knowledgeable about the anatomy, the pathophysiology, the surgery, the cardio bypass, the hemodynamics, the pacemakers, the medical dosing. They should be able to act on time to save those patients. Family and the communication and the presence of family in the ICU is very important to make your life easy, especially in those chronic patients. And staff education is very important. It's a continuous process. They have to have continuous training all the year for new things and to recertify themselves for all things. The zero conflict unit is not healthy. Too much conflict is also not healthy. So we have to deal with conflict in conscious effort. Minimize this by knowing that all work for the same target. We have to have standard operating procedure and policy and procedure, because this will prevent and minimize the diversity from practice. And this diversity from practice make the conflict happen. Also, very good communication between all the staff is very important to minimize the conflict in the unit. Complication will happen because we're dealing with sick patients. It can happen by chance. It can the patient is sick. When it happens, I want to read this for you, because it says such an event occur, attempt to blame individual involved in the care pathway can generate unnecessary conflict, upset the group morale, and add to the work stress of the team member. So it's very important. Analyzed, identified, to be performed, to work on this to change and made the protocol and system to prevent this from happening in the future. Decision making in the ICU is very important, and it's important to make it clear to everybody that the primary caregiver should have the full authority to take the best course of action that he or she feels appropriate for the situation. For example, if the bedside nurse is there, the patient has arrhythmia, she's the only one there, she can do cardioversion for tachycardia. She can call and the ET for the ET tube if it's blocked to be changed. So for these things, the primary caregiver should have the full authority to do things that save the life of the patient, rather than waiting for the second line to come, and it might be too late to do this. The last thing I want to discuss with you is this new practice that actually recommended by the Pediatric Critical Care Society. This is a recommendation from this society, where they are recommending that the cardiac ICUs start using the advanced practice provider or nurse practice. This was published in 2014, its details, recommendation. Actually, they give the authority to nurse practitioner to order labs, prescribe medication, perform invasive procedures. They have to go certain training to be able to do this, because it was proven that the nurse practitioner service have not only reduced the cost, but also reduced the mortality. These are the big 6 hospitals in the state: Texas, Cincinnati, Philadelphia, Stanford, and you can see Dallas as well. You can see the first line is the number of beds in each hospital. The second line is the number of the ICU bed, and you can see it's around 5 to 10% of their ICU, their beds are ICU bed. But look at the third line. This is the number of nurse practitioner in each ICU. Every hospital has this facility. Actually, some of the hospital has more nurses practitioner than the bed they have in the ICU. So actually, I was trained in a unit in Montreal with 3 nurse practitioners. Actually, I learned from them maybe more than I learned from the consultant in that unit. It's very important step because they maintain the care, keep high level standard of care for those patients. I hope I was on time. The take-home message is the ICU care of teamwork. And I like this quote from one of my friends in the hospital: "We are as strong as our weakest member of the team." Remember, perfect design and advanced technology does not work without competent people. And it's already too late, so you can go to bed. Thank you very much.
I appreciate Dr. Abdullah, and definitely you've been on the time very well, and very interesting talk, and shine the light about aspect probably nobody think about it, but definitely is very important in terms of the design and thinking.